Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 188. We have an exciting left main trifurcation case for you today. You're probably going to learn a lot of tricks about selection of guide wires. Do you need to wire all three branches? Can you get away with two? The role of imaging and many other practical lessons. Be mindful, you will get CME, just a couple of simple questions to answer after that. With this introduction, let me take you to the cath lab where Dr. Kinney and Dr. Sharma are standing by. Samin, good morning.
Good morning to our audience.
And any improvement in the response from the CME?
So I think it's a more the archives. So what we have done now, that doesn't have to be live, that archives, because they'll get the link after the case presentation, case ends, and then it's available for 1 year. So archives now, they can get the CME on the archives cases. Also, they want to do it live is fine, but we made it both live as well as the archives, because archives we know is our biggest audience. With that note, with the very cold weather of the New York City, we are ready to start, a little late and sorry for it, but let's go to our clear presentation now. As you mentioned, the trifurcation case, this we are going to our CCC live, target audience accreditation, which is a little change compared to the earlier one. So privacy policy and so which we are writing, and our faculty disclosures remain the same is our commercial support, and so on and so forth. So with that note, case number 188, one of the youngest person which we have done now, 37-year-old male who presented with class 2 angina, had a symptoms but had a negative stress test. Would you believe that? The classical symptoms but negative stress test, but the cardiologist ordered the coronary CTA, which showed multivessel CAD, with positive ctFFR on both right and left side. No prior history, hypertension, hyperlipidemia, and you can see SEQ score 52, BMI 23, A1C, LDL, CRP, serum creatinine, all within limits, and aspirin, amlodipine, metoprolol, torvastatin. Cath was done, which revealed 3 vessel plus left main CAD, consistent with what was seen on the CT. And but only difference was RCA FFR was negative, which was positive on the CT. But patient had the ulcerated left main, and we'll ask Anu to show that with the EF of 60% and syntax score of 34. Because of the left main and high syntax score, we referred the patient for surgery, but patient family declined due to young age. Anu, you want to show it? Okay, yeah. Let's go to the angiogram now. Yeah. This
so we have, EDP was 18 today. Okay, but you see that apex, I would say a little bit hypo, no?
Yeah, definitely little hang up, but yeah.
But
overall normal, yeah.
And then this is the RCA. This is with nitro. Actually, if you had seen originally, there was 30-50 proximal, mid was also is there, but we have did the FFR, which was negative. And this is where we are with the left main. Ulcer there, distal left main. You have a ramus, significant disease, proximal circ, significant disease. I will show you a better one. That was 7.5. So what we are doing is, most of the diagnostic we are doing 7.5 frames to decrease the radiation. Now we are 15. So you can see the ramus, significant disease, ulcer of the distal left main, proximal circ, I would say moderate, right, 60-70, and then this is the cranial. Proximal LAD, significant disease, and DAG is okay. Then after the DAG, another of 30-50, but then distal LAD has some disease. This is where we are.
Yeah, so rest is our same of the cath lab team here, which familiar faces with the Kiski on the IVUS, and of course we have 2 fellows, Pratish George and Gaurav Arora, and will be helping us ready with the 7.5 French catheter. So if we can go back to slide presentation, we completed.
Samin, first of all, welcoming numerous people who have joined us from all over, including a person, it's just written Dr. Joe from Croatia. Welcome to you. Samin, in one of the views, it even appeared as if the left main could be related from trauma to the catheter?
Yeah.
No. It
So
was
no,
there even
we actually have it back then.
in the
Same.
diagnostic.
Remember on
Got
the
it.
report I wrote down, it was an ulcerated left main, and it is only 60%. Actually, on the CT also very classical. We thought so even originally, but it was on the CT. So that's our goal today. Trifurcation, put a 2 stent with a mini crush, and third branch as an atherotomy, whether it will be the ramus or the proximal circumflex, based on the guidelines or appropriate use criteria. As you can see, it will be appropriate after heart team discussion. That's where we are now. So Anu, you are ready now?
Yes.
We are taking with the guide catheter nitro given.
Yes.
Yeah. It's a 7 French. Okay. It's a non-calcified. So let's start doing the cutting balloons and so. And then we use IVUS. We are ready in the end to optimize. Tell us your strategy now. Which 2 vessel you want to stent, and the third one you just do atherotomy. So we clearly are not a believer of 3. Some people will put a 3 balloons and this and that. We never do. We will do a mini crush, and if there is still a branch gets trouble, then you can go through the mini crush and do a kissing balloon of the side branch. So that's what we have done many of our live cases as well as in our CCC live here with the trifurcation. Now, we still repeated the FFR, which was positive on the left side. It looks like that ulcer, maybe nothing there, but it was positive on the left side. Right, as mentioned, was negative. We didn't do individually for the circumflex. We just did the left main to the LAD FFR a few weeks ago before the patient's CABG. Refer for CABG. Yeah.
Let's capture a few very relevant questions. First of all, this is, I only have the name here, Mohammed. His question is, did they do a LP little a?
Yeah. So have you
LP
said
little
that?
yeah, normal.
Okay. Normal. Okay.
Yeah, we checked all that.
Yeah.
Now, the other part is, this is Dr. Imtiaz Ismail, who raises a very important question that it's just that the coronary CTA put an end, otherwise this patient would be doctor hopping, going from one to the other place.
Well, very soon it would have been on the pathologist table. The guy would have been dead, would have done exercise, not knowing it, because the thallium stress was not done anywhere at Mount Sinai. We did it here. Our patient went about 8 minutes, equivocal ST segment depression, but nothing, but whole, I think it was all balanced ischemia, was completely normal. So we have documented here. Yeah.
What made somebody think of doing a CTA after the negative?
Because of symptom. I can tell you, I would have sent patient for CTA to begin with, but who ordered the CTA? Do you know? Huh? But doctor, I mean, because of the classical symptoms, they didn't believe it. But I can tell you, for my point of view, screening, and now with the European Society, that if you have a risk factor, you can go with the CT as a primary modality. And that's what I believe. Personally, I've been believing that for decades.
Can we just make a decision which way rather than...
Yeah, good. Tell us. Yeah.
Okay,
I recollect...
no, can we just decide what you want to do?
Yeah, no, that's what we are talking. Yeah.
90% ramus, okay?
Yeah.
That's the one, even if you do mini crush of the left main to the circ, ramus will then compromise.
That's a very good point. So I would say in this particular case, it's easier to do a mini crush of the left main, LAD to circ, and ramus, do a cutting balloon, because if you need to put a tap, it will be easier to do a ramus rather than if you go other way around. Yeah. This, and then you can go directly.
I don't know, it'll go like this
to
the stent strut.
Good. So let's do cutting balloon, what, 2.5 cutting balloon, 2.75, what do you have?
We didn't open a cutting. It will be a 275 cutter, no?
Okay, 275 cutter. And you need one more wire, right?
No, I don't want 3 wires.
Okay.
Let's do this and then take it out and go to the circ, right?
Okay. Okay, we are doing the ramus cutting now. And have you done the IVUS? You want to show that ulcer, that truly
it's
ulcer?
I don't want to do the IVUS right now. Let us, because it's significant.
No, I think it will be interesting for the audience to see what that ulcer looks like.
Yep.
And what will we do after that?
No, it's just the theoretical understanding. No. Ulcer crater. Good.
Final treatment stent, so.
Yep. Okay, so we are ready with the cutting balloon. 2.75 Wolverine.
Okay. Okay, Vikiski is giving me hints. He wants IVUS. Okay, give the IVUS.
No, but let's cut the rim. Oh, you want to do before even?
Yeah.
Okay. Okay. No, leave it. Good. They are the
So I'm
IVUS.
going from left main to LED.
Sure.
That's it.
Okay, that's what he wants.
That's what will reveal the ulcerated plaque there.
Yeah.
So, I mean, with the so much increase in CTA, is this happening more and more often that the stress test, including a stress thallium, is equivocal and you have
Very
to lean
common.
to a
Who
CTA?
pressed?
Yeah. Very common. I would say that it's not uncommon because stress test is, it's
Okay,
so
start.
many times negative.
Check the image. Can you show the IVUS on the screen?
Flush.
All right.
Wait. 1 second.
And I have seen particularly in South Asians, which this patient belongs to, South Asian, very common.
Okay, it's like a mid LLE. Okay, I'll start pullback. It's coming. Yeah, some eccentric plaque, some dark plaque. Yeah, big bunch, blocks LED, left main, and short left main. I'll stop it. So first I will check the
Did we
distal.
get the ulcer or you think the guide was covering
No,
it?
sorry.
No,
No, I thought there was something
yeah,
right
okay,
towards
okay,
the end.
yeah,
That's it.
we saw
There
it.
you go.
Nice.
Yeah, it's
Look at
There you
yeah.
go.
So,
Classical lipid edge of the lipid has been washed out.
you
Look
see,
at that ulcer.
Yes, 6 to 7 o'clock. This is the cavity. This is the
Cavity.
Flush.
Lipid
ulcerated
cavity.
plaque.
So that
Flush.
also speaks
Fix
for
it.
that this is not the trauma, it is the natural disease.
Yeah, maybe previous rupture, like
Yeah.
silent rupture.
Yeah.
Yeah,
Good.
not that much calcium, mostly like a dark
I'm
lipid
saying what they're
plaque.
doing.
And a huge size gap, LED, and left main.
Advanced. That one. Yeah, good. Yeah.
Diffuse plaque.
Okay, hold
Okay.
it. Hold the wire.
Kiski, how much is the diameter of the distal left main there?
The left main
Almost
size is it's true. So AI can generate like 4.8 vessel. The EEL more than 4.5. That's the left main size.
Yeah. This
But
is
the
left main style.
LED is 3.5 vessel, so huge size gap.
Yeah, little wire entangling as you can see there now, which is not
no,
uncommon.
no, that's not the issue. I think issue was the significant
wire
disease,
entangled, yeah, but
disease
yeah.
of the
This is left main.
osteal ramus.
Yeah, sure.
Yes. Okay.
Okay, we are ready there now. It's a 2.75 Wolverine.
Careful. Don't get
So
too
the first
Well-
Samin recommendation has come
down.
DK crush LED left circumflex and DCB of the ramus.
Very good point. So yeah, so question is what we are going to just modify there is this cutting balloon of the ramus and mini crush. I know a lot of people are with the DK crush, but we are a big believer of the mini crush, and that's what we are going to do.
Same
nothing
result
wrong in
with
yeah.
simplified
Simplified approach.
strategy.
Yeah, that's correct.
Down.
So few times back and forth so that do enough cutting of the circle of the ostium of the ramus. And I can tell you the whole country is big, whole world actually becoming gaga with the DCB. I can tell you our personal experience has not been
Take a
good
picture.
with the DCB. I mean, even the ISR cases. I mean, I know this has been approved for this purpose.
It's a dissection.
Yeah, that's okay. Dissection is good.
Now we may lose the branch.
No, we'll not lose the branch.
You mean at the superior aspect of the ramus?
Yeah.
Yes,
Right.
yes.
Yeah.
You know, it's amazing. I'm sure there is a little underfilling, but if you take a look at the three vessels, the circumflex appears to be the largest.
Yeah, exactly. Even bigger than LED.
Yeah, even
No,
bigger
no.
than the
Okay.
LED.
Distally, yeah.
I'm sure it'll perfuse with the, but very large circumflex.
What do you want to do now?
No, we have to
You want to
cut,
leave this
right?
wire? No, use the third wire. In this little dissection, leave the wire. Get one more wire, please.
We just said we are not using
No,
three
but
wires.
no wire. Wire we can leave three.
No.
But not the three balloons we are talking about.
Okay, get us the same cutting balloon. Okay,
Yeah,
let's
same.
cut it.
Yeah.
Little
Um,
damping of the guiding cath.
Yeah, ventricular. Yeah.
Yeah.
It was right from the beginning.
No, not run through.
Hmm?
Fielder.
That's okay.
Huh?
Run through also.
Okay.
Yeah. Run through is okay too.
Okay, don't open. Let's use it.
Yeah. So 3 wires. You're on the floor.
Anu, this is a question for you, and I don't think it even matters asking this question before or after the case. I mean, this is a 37-year-old with such extensive disease. Lifestyle management is going to be the key, no?
Oh,
Yes,
absolutely.
yes. Lifestyle management, I tell patients, and you can put it on your website. We have on the chat there, we have created a website called CardiFit, CARDYFIT, where any patient that comes, they get the access to it, free discussion of all various diet, simple exercise, yoga, meditation,
Good.
videos are there. I talk a lot when I see the patients in the office. After the procedure, when I talk to them outside, family, we give the card. We do
So
as much as we want, but the commitment
Anu,
is not there. Commitment is not there from them.
how
But
do we make more physicians believe in this too?
Go.
That's exactly what I'm saying. There's no commitment neither from the physician or from the patients.
No, but
Anu,
this particular
yeah.
particular patient has a low BMI. All the risk factors are well controlled. So this is not even much family history. So this case just, I would say the Western hemisphere migrating to USA.
Well, 5,000 years of yoga has been destructed by McDonald's. Anu, questions for you, and I'm going to read it as it is. Congratulations to Dr. Kinney on publishing Yellow 3 study.
Oh, thank you. Yes.
So-
No, I was just going to say to Dr. Sharma, Yellow 3, we have now identified important genes, which I showed you, right? There are people whose LDL was in their 30s, okay? But still, there was no change in their plaque, which means thin cap we saw. So why that happens is because of some kind of their genetic makeup. So that is where we are going to understand more. Like this guy could be one of those person.
Yeah.
His LDL could be normal, LP-Little-A is normal, everything is normal. What we found was same. They have some defect in their mitochondria.
Exactly what we discussed in detail, I think, during the last session. Anu, follow-up question, is this familiar hyperlipidemia, and will you send the patient on Repatha when he goes home?
His lipids are okay. LDL was 1 point. See, I saw him and then started him. So you have to see his what is his
100 now.
BMI?
Yeah.
His BMI is low.
23, yeah, very
23.
low.
So very low. So if you see that, we started him only on Lipitor of 10 because Asian patients, you know what, they do have side effects of myalgia with Lipitor. So we started with 10. We are going to repeat his LDL today. So it was LDL 102, HDL is 41. So how to increase HDL is only by one means, exercise. You got to do some cardio.
But still
So-
41 is not too bad. Go further. We have to go a little further.
It's not too bad. 41 is...
Yeah.
No, I
another
think it has to be above 50 minimum.
question,
You want
it
that?
could,
Good,
it could
done.
be answered by either of you or by Kiski. What were
2
the
millimeter further.
IVUS criteria to use cutting balloon hair?
Oh, okay. There's no, in the sense, remember the IVUS criteria for cutting balloons does not exist as such. Now, if there is, we did not see any calcium, but definitely fibrous plaque. And in all our apps, which is bifurcate as well as calcificate, what we say is that if you have non-ioto-osteal, which is like here, osteal circumflex, osteal diagonal, osteal ramus, fibrocalcific, and not calcium, more of a fibrous osteal lesion, they respond better to cutting balloon.
Yeah. So what happens is otherwise with the high pressure, you'll go to a non-compliant high pressure, and that may create more dissections. But yes, cutting balloon does cause some dissections also, but that will cause more dissections, yeah. Tell them your thing fell off. I mean, how can that be? Call this person, yeah. Go a little further. Go there, I know, but.
No, but look at the ramus.
Yeah, ramus is getting more trouble here. I think we may have to change the strategy. That's what AK wanted anyway.
Yeah, exactly.
Good.
That
Okay.
was my.
No, clearly
kept
that
saying.
I think that's a very important point. Our initial plan was circ. We can do the circ later because Ramus is going to close otherwise. So we had to do a mini crush now into the left main and LED. So let's get a 3.0.
No, hold on. So left main, what you want to do? No, LED, what you want to do?
Yeah, 3.0. So 3.25.
No, you want to use the same cutting balloon? No?
No, leave. Okay. Yeah, let's do a LED cutting balloon also.
So why I predicted that was, if you look at the lesion, right?
Tightest lesion.
Yeah, tightest lesion when you dilate, no matter what, that is what the balloon is supposed to do. It does cause dissection.
I'll go with the 3.5. The
Left main to
what you want
LED.
to do, yeah, and
Okay.
3.0 there.
Okay.
Both 28,
Ramus.
28 maybe. Go.
No, I don't know 28 to the Ramus.
Ramus
We
could be
never took
23.
a cranial picture. I have to do a cranial picture.
Yeah. No, they use a long 38
No.
LED. LED.
Cannot.
Why?
We are not going to the diag. 38 will cover
Okay,
the diag.
then fine. Then 28
Yeah.
or
Oh.
23.
Just after the septal.
Yeah.
Or let's ask Kiski. We are saying 28.
Yeah, before the diag, there is also eccentric diag
Yes.
plaque, but the lumen is like 3.0. Vessel size is more than 3.5, but the diffuse plaque, so maybe 3.0 or 3.25 is safer. It's on the lipid plaque.
No, I know. Then we are coming up to the mid left main. So we are saying it's 28.
No, but after the diagonal, how bad is the disease? That's the question.
Yeah, so after diag is also some
Look
eccentric
at this. Very
plaque.
good.
and,
Less than
yeah.
3. You put a long one. That's okay. 38.
38 will not cover it.
Then 48.
It will stay on the lesion. Then it will be 48.
48.
35 is no. Then you have to put 3.
3 to 5.
3, 5.
3 to 5. Let's just our giants. Go.
Okay.
Let's cut the LED. Now we are doing the LED cutting with the same cutting balloon.
Oh, you have to go after the diag.
Yeah. You had
So
to
you're
put that.
saying Kiski after the diag was significant plaque also?
Oh, yes.
Angiographically was there too.
The only thing is I have a. Okay, go up here. So they had the question, right, why we use cutting balloon, and on the IVUS, though angiographically we do see speckles of calcium. What do you see? Did you see anything
No.
on
Not
IVUS?
much,
Down.
not minimal.
No.
There was in
Down.
Yeah, less than 90-degree Carlson.
Yeah,
It's a
very
mixed
little.
plaque, but mostly dark and fibrous. Lipid
Yes.
and fibrous.
So fibrous plaque also responds better to cutting balloon.
so this is a 3.0 Wolverine.
No, same 2.75.
2.75,
Which is done in all the 3 vessels.
Right.
Same. And as I said, strategy change. Let's get the stents ready, guys.
So if you had
Yeah,
more
3.25.
calcification, you would have been using rotablator.
Yeah, that's right. Go. Then 3.0.
What is the?
48. No. Here. Wires are coming.
Okay.
Good.
Go up.
Yeah.
Careful there.
Mhm.
You have
Low
to-
pressure here.
So then you want to go 3.0.
Yeah, 3.0.
What's the left main, Kiski? Down.
Left main is 4.5 vessel.
4.53.
Yeah.
Yeah.
But start of the pullback is like a 2.75 vessel.
Wait. Down. Then do you want to put 2 stents? Because it's 2.75,
Yeah.
4.5.
Huge
Yeah.
size gap.
That
I
doesn't
think
make any sense.
We can use a 2. Yeah, good.
Good. So we can go 3.0, 28.
Yeah, let's
Let's
get
do
a
a cranial.
3.28
Wait, let's
first.
do a cranial picture here.
Yeah.
Okay.
So let's go to osteum. Cut
Okay.
osteum 1 second here. And then we'll go take a picture. So I think this is
Go.
a reasonable case that you use a 2 separate stents in the LED. One into the mid LED, another one proximal going into the left main.
Okay. Down.
Just because of the significant disparity in size.
This-
Yes.
Go.
Cut the diag.
Yeah, that's okay. I will be all right. Good.
The LED, not unexpectedly, has become much larger.
Yeah.
Is, I think under perfused before.
Hold on. 3.0.
I was
3.0.
about to.
3.0, or you wanted, 1 second, let me decide. See, that's why I did not want to go distal to the diagram.
No, but you need a very tight lesion. Yeah.
I don't know.
Put a long
Anyway,
one, that's
30.
okay after there also. Make a 3033.
Okay, get us a 3033.
3033.
But the diag is not looking healthy.
Yeah, there's significant plaque shift there. Significant.
It's too much.
So the 3-vessel disease became 4-vessel disease.
Yeah. Yeah.
So so based on how we respond to the statin, because this is the guy, you need his LDL less
LDL
than,
to like 50.
yeah.
This is the classical one. You want to bring it down to 50 or less than 50 even. Whether you use the PCSK9 or
Inclisiran.
yeah. Actually, it's a big fashion in India now. Inclisiran is available there.
Yeah,
Everybody wants that now.
1/10 the cost.
Yeah. Ready?
Someday, yeah. Pull back. No,
Good.
this is
Have
good.
you had several patients on it?
Oh yeah. Yeah.
Tolerating well?
Yeah. Tolerating very well. We actually were the first early
Done.
adopter of Inclisiran, but two of my doctor friends.
You are 15, 3, 5, 15.
1 second, let's go up. Right?
Okay.
And then a little proximal pull. 14. Yeah, Ramus wire has to go a little further in.
Because that's a broken now.
Yeah, that's fine.
We may
That's
need a
even
new
better.
one.
Good.
That'll
Yeah. Good. Here, let's open it. Here, that's it. That's it. That's it.
Okay, down. No EKG changes. Hopefully diag is okay. Fine, take a picture.
Okay.
So now I was suspecting 15.
No, maybe longer.
Okay.
Yeah. Remains. Okay.
What you
Go
want?
to other view now.
18?
18.
3,
yeah.
5, 18.
Yep. Go to the other view now. Caudal view.
diagonal flow is very good.
Yeah. Yeah. We leave that alone. Yeah. And 3023 for the Ramus. 3.5 18 and 3023.
And again, your intent here would be multiple stents in different wires. Try to use the same
Yeah.
stent
right.
from the same manufacturer.
That's correct. 26.
34.
Sorry, 34.
No. 26 is LAO, caudal 34. Good.
Okay.
Now only issue is the wire in the circumflex is
Yeah, we can
run
take it
through.
out. Yeah, we can take it out.
I think we should take it out. I don't want to leave that wire
Yeah,
there.
that's wire we can leave. We can
Let's
take
place
out,
the stent.
Yeah.
Okay, now what is this?
3518.
Okay, goes to the LED.
No,
No,
but
first
go to
Ramus.
Ramus.
Give me the Ramus stent.
Yeah. Yep.
Oh, is good enough?
Yeah. 3 is okay. Minus. Good. Yeah.
Now remember you have to come all the way to the left main.
That's okay. Good. Okay, so 3023.
118. I mean, 28.
At 9 o'clock, I had to for 5 minutes for a good jazz thing with my PRRC.
So you're going after the Ramus now?
Yeah. Ramus first and then the left main LED.
When we recross kiss, you can start your lecture. Okay, I'm going to take out the circ wire out, okay? Ready?
Yeah. What do you want?
Okay.
Yeah, good.
So this is the key, exactly the position of the very proximal part of the stent, no?
Yeah, that's right.
Into the, as so far as it pertains to the carina.
That is correct. So basically we'll do a little bit of, few millimeter crush. And that crush will cover the ostial circ also.
Do you have left main mini crush, Felipe?
Welcoming also Dr. Mohammed Omar from the UAE.
Beautiful. Good. So the ramus stent was, sorry, advanced a little bit. Yeah, no, but yeah, good. Now go.
Wait. No, I think it's short.
You want longer? Yeah.
Right?
Okay, 28. Take it out. We have to contiguous. We have to contiguous. It's not there. Look for a 3.5 28, right? 1 second. 1 second. Yeah.
Hold on, hold on, hold on.
It may
Make a
be
select.
okay.
You want to see where we are?
You have to give some dye. I think we are good. Because, okay, good.
Yeah, maybe okay. Good.
Okay, hold on. We have to do cranial and caudal, unfortunate. Okay, wait. So, give me some dye.
Sine. Let's take a sine then.
Okay, so very important that you cannot double cover the septal.
That's fine. We're okay.
Okay.
That's a very, very useful point, Anu.
Good.
I think
It's a major
Go to
septal.
caudal view
important
now.
for
Which is
people to...
ramus, this one?
This one, yeah. Go to caudal view.
That's why I have to come back to the cranial
Right,
to confirm it again.
right.
Okay.
You know, so much careful, meticulous techniques here, young person to get absolutely the perfect result.
Okay, some dye. Okay,
Good.
now. Okay, ready? Picture.
I think looks good.
Looks
No.
all right.
No, but ramus has to go in.
Yeah, I'm going
Too
in
much
with the ramus.
out. Mega crush.
Okay, now ramus.
You're still there.
Even further.
You're there, yeah.
Okay, now.
Yeah, you'll die.
The thing is,
That's
you
good.
have
That's
to,
good.
no, you have to remember,
Yeah.
you have to cover the circ
Ostium.
completely
Yeah,
if you have to
agree. Yeah.
re-enter.
Good.
So you
That's
cannot
good.
have half some dye. So, okay, let's confirm that.
Yeah,
Yeah,
good.
it's completely covering the circ, and that's the way it has to be. Okay,
Right.
but go up with the ramus.
To enable crossing into the
Yes,
circ.
yes.
Yep.
I mean,
14
the
atmosphere.
crush could be a little bit more than we want, but if we want to go back to the circ. Okay, down. Little dye. Wait. Good. Not yet. Okay, good.
Isn't that right?
No. Okay. No, Sine, dye.
Okay.
Good.
Good.
Now I have to confirm. Where is the LED?
Yep.
Some dye for the LED. I have to pull back. It's covering the septal. Okay, now.
It looks good.
Okay, now some dye.
Are you overlapped distally?
Yeah.
Yeah.
Okay. Yeah, go up.
Another
Okay.
question popped
16,
up.
yeah.
Would you do this case from wrist axis?
Yeah, with the wrist master can do it. Yes, nothing wrong in that. But you need then you definitely will do a DK crush.
Down.
You'll not do a mini crush because 7 French, more and more data, 7 French, more trouble with the radial. So go further, yeah. So I would say that can be done, but in that case, I would prefer the DK crush rather than the mini crush, which is okay. Nothing wrong in that in this particular case.
Okay.
Good.
Go up here.
Good. Yeah.
Get us 408 balloon.
408.
You start your lecture. So what we are going to do is we are going to do the pot 4-0 for the left main, then I'll recross and case.
It will need only 5 minutes from 9 to 9:05. So let's
No, no,
conclude
we'll be
the
done.
case. No, will
Oh,
not be done.
oh.
No, will not be done.
Yeah, that may be a better strategy to finish the case. I mean, then you take your call. And
Yeah.
thank you for all our viewers for keeping the case
Yeah.
interactive.
Very interactive. Yes. Let's take this balloon out. And let's get
Okay,
the nitro now.
very important question, Samin. This is directed for you. I'm going to read it as it is. Is it true some stents?
Nitro. Yeah.
Is it true some stents end at the dot and some stents are at
Yep.
the dot?
That is
Creates
correct.
confusion when nailing the ostium, etc. Maybe Dr. Sharma can tell us which stents are those.
Yeah. So
No,
I can
no.
tell you.
Okay, let me give, before we do anything, you can ask my fellows how I train them to do ostial. Never ever you know pay attention to the dot. You ought to pay attention to where the stent starts. So it doesn't matter which company is saying it's on the dot, inside the dot, as long as you are watching that where the stent starts. That way, no matter which company it is, you'll be able to nail the ostium.
Yeah, having said that, I think because when you are taking a picture with the deflated stent, not ready?
No.
Go up.
Pot.
Yeah. So there, all the synergy, promus, they all end inside the dot. They start actually, I mean, inside. Compared to Zions, Onyx, they are all at the dot. So therefore, many people actually ostial, they don't use the synergy for that purpose or promus for that matter, because they're not clear. Ready?
Yes.
Anu, very sophisticated audience watching carefully. Here is a question for you. Did you post-dilate Ramus stent with stent balloon after withdrawing it in the left main to ensure ostial opening?
No.
No, we're going to do it now with the kiss. Good.
Go up.
Moderate pressure. So we are going to do a kiss now. This is just we are doing a pot. Now rewire. We have that fielder wire ready.
Down.
This is the 4.5, 8?
4-0.
408. Okay. Good.
Give me the fielder wire.
New fielder wire.
Yes. That fielder was gone.
Yeah.
We can take a picture now.
Yeah, I thought that would be very useful to see how.
This trifurcation as shown. Good. Ready? See to believe it.
So far, so good. Everything
good,
looks good there.
Good. Okay, we can use a 2.75 for Ramus. What do you want here? Or 3.0? 3.0 20. Non-compliant. Good.
Really, if you look at it, even without the case having been completed, the amount of increased reperfusion there. I mean, look at the...
Super. And the question what we are going to avoid is opening this routine circumflex.
Right.
Because circ looks good as long as we do a kissing with a 3.0 and we can have a 3.5, or you want to keep the same 4.0 for the left main LED?
3.5. Get us a 3.5.
3.5. Yeah. Get us a 3.5.
What are you doing? 3.5, what you gave me? No. Who asked 20? No. There's no way 3.020 will get into the Ramus. 3.012.
I know, is this a new wire?
Yeah, this is a new fielder.
Right. Probably needs more shape, no?
Now we have
Maybe
a
not,
shape, but that's not the thing. It's a lot of crush and
Yeah.
you remember all my procedures used to be with the Promus stent, but Promus has closed their plant. No more Promus.
So this is the question. Remember at before you started the case today, I said I'll ask you something pertinent during the case. Are you concerned that almost every device company is paying so little
How much it
attention to coronary R&D, developments, everything, just because there really is no money there for them. I mean, everything is going into structural heart and
Okay, some die.
CHF devices,
Okay.
and the availability also.
So you have a 3012. I don't know whether it will go. So now get me the 3.5, right? What length you have? 3.5. No, you cannot. No, you did not open 3.5, right?
You don't think 3.0 is the right?
3.5.15, because I may have to anchor it in the LED. Give me the 3.5 into the LED. Oh, you mean the lengthwise to kiss? Side branch, the longer balloon may not go in, because we are going with high pressure to begin with. If it does not, have a 2.12 ready. Since our crush was a mega crush, okay, not a mini crush, to cover the, this is 3.5. So I'm not even going to try, I'm going to anchor. So we go into the LED, then the 3.12 is ready.
Yeah, there are people who were concerned with the 3.5 there.
Where? Now I'm going in the LED.
For the Ramus.
We're not the Ramus.
No.
This is
I'm
LED.
saying, no. When you mentioned at that time, it was not clear.
Okay, go up. Don't go, stay there. Okay, give me the balloon for the 3.0. 2.12 is ready. Don't open. If this does not go through. Good. So our mega crush help. This is a 3.12 balloon that has gone into the circ. So that's what we normally see. Yeah, it went.
Went
Okay,
very
go up.
easily.
Go up. Yes. Wait, pull back. Okay. Now go up here. 18. Okay, good. Down. Now let's do the kiss. Come back here. IVUS is ready.
Yep.
Okay, now LED go up. 18. And then we'll do the kiss. Both the balloons are there. Good. Down. Now go 8. Okay. Is it more good? No. Okay. Down. IVUS ready.
Yep.
Any questions on the steps? Did you find
The next totally different area, although we kind of were that towards the beginning of the case. This is Nikhil Jha. Nikhil, welcome. Any genetic testing in this young patient with the significant severe CAD?
I don't know. That's my goal in the yellow trial. We are going to come up with a biomarker to understand these patients, responders, non-responders. That part of my research work is still going on. So of course, give us few more years, we'll come up with something. But right now, other than like the discussed already, familiar hypercholesterolemia, which he does not have, I don't think there's anything else. Genetics. Go, keep going. Now, one thing I'm a believer of, but I know there are certain studies, but not truly prospective randomized study to say, okay, we understand you're doing exercise, you're doing a lifestyle modification, but the so-called, I'm going to the Ramus. Okay.
Sure.
And the so-called eating saturated fat, junk food, even if your numbers are right, okay, I am a strongest believer that they cause endothelial dysfunction. And life is all about endothelial dysfunction and mitochondrial functioning.
So another question, is
Can you
it
show the IVUS on the
necessary
screen?
Start.
to,
Yeah. Can you show the IVUS on the screen?
This is the ramus.
Yeah.
What was the question?
is it
start
necessary to
pullback.
deflate simultaneously while,
Ideally, yes,
This is
yes.
from limus.
Because
Native
you
part,
just
no
worry
plaque
that
here. Yep.
you might
Edge
have
looks
caused.
very smooth. Good expansion. Now left main. Short left main.
Good,
Come
right?
to the ostium. Yep.
Yeah. Ostium is good, right, sir?
Yeah, well expanded. So this is the
Okay.
osteolimus, like circle shape, and a distal left main also looks circular shape.
Keisuke, there was a question you could answer. Do you
Yep.
think the ramus came from the left main or from a paraosteal circumflex?
Yeah, I see at the level of the bifurcation, I see the sleeve branch. So I think it's a trifurcation.
Mhm.
But anyway, stent looks
Where is
good.
the stent? Is it coming up to the ostium?
Yep, because I show you the bifurcation. So this is the level of the distal left main, and you see the catheter in the limus. And from 3 to 4 o'clock is the LED, and a good shape of the stent, like no protruding metal mass. It's a well modified mini clutch. And yeah,
Needs
It
a
should.
little over post dilatation in the left main, or you're happy?
proximal part like a minor malposition, but stent is, sorry, this is not correct.
Show me the ostium. We are like 2 millimeters inside, right?
Uh, One second.
So right
anyway,
now-
the area is 13, and
Yeah.
this level, you see the level of the aorta, but other part is still in the left main. So almost at the osteal left main, the proximal edge.
Means we have nailed the ostium.
Yes, exactly.
The term is nailed the ostium. Yes,
And the
good.
limus stent also looks fine, and no distal edge dissection, no malposition.
Okay, good. Now I'm in the LED. Go.
Sure. Check the image. Okay, start pullback. This is from LED. Native. Yeah. Edge looks perfect.
Nice.
Yep. Well expanded. Some eccentric plaque behind, but area looks good. I'll come to the bifurcation, left main. Yeah, same.
So Keisuke, from your point of view, we are done?
Yes.
Looks good. Both pullback looks perfect based on the IVUS.
Okay. Now let us take final picture.
Yeah,
Some
proximal
nitro.
LED area
Now we are
like
going to
8.
About to
rehabilitate
ask
the
you about
distal
the
vessel,
nitro.
nitro, verapamil, some
Yeah.
things for the
Left main like
distal
more than 10.
vasculature.
It's an optimal result.
Some verapamil also. And now the once he was seen in the office by the surgeon, he was seen in the office by me. We explained the risk benefit of PCI versus bypass. Then when he said he still wants PCI, then we had given him Plavix. I won't say loaded. So this was almost 2 weeks ago. But today PRU is 206. You want less than that? No, he may, because there's a risk of bleed, I know, but he may still. Will says he wants the PRU less than 200 and wants to give, since we did 3 stents, left main, young guy. What do you want to give, brilliant or efficient? Efficient? Okay, he wants efficient. Okay, we take the wire out. Okay, good. Wire is out. Any questions, so anything so far?
Many suggestions that prasugrel would be good here, and back to the, I think we had discussed this earlier, whether there would be much of a role of drug-coated balloon here. But that I think we had discussed earlier. Are
You mean the
concerned?
ramus drug-coated balloon?
Right. What about the ostium of the circumflex? Are you concerned?
Yeah, there is some. No, I think that's to be
something
left
is there.
alone. Yeah, type. Yeah. type
very
A.
faint
Yes, yes. I'm going to
dissection
do
also.
another caudal picture. Let's make sure the diag is okay. EKG is okay, right? We have to check if any chest pain. Yeah. Wow. Look at that. Beautiful. We called artery like he was born with. See that? Nice. Okay. Yeah. We are going to discuss.
Yeah, this would tell us about the circ.
I think to be left alone. Non-flow limiting, no?
What about beyond the ostium and the little slightly more distal where there was a plaque
Exactly.
to start
That
with?
was, that was where it was. Since they wanted to stent, Dr. Sharma kept asking me, go down, go down. If I was doing originally as I had planned, thinking that I will stent the ramus, I would have just done the ostium of the circ to keep it open. But I think that this will stay open.
Okay. Anu, a question came, we didn't get a chance to discuss it, maybe because the EF was very good to start with, but was there any in your mind, yours or Dr. Sharma's, consideration of impella here?
I mean, normally EF, no, there's no indication to be doing it, but then if somebody is trying to do this procedure in the early part of their life and they want some help, probably a balloon pump, rather than an impella.
Several viewers have picked up on the left circumflex dissection.
Yes. I think it's should be part of our training also, that when you can leave things alone. This is a case where you can think
and follow-up observations, it will heal well.
Yes.
Leave it alone.
Yes.
So that is the course which we have taken. Excellent result with the left main, proximal LAD, ramus, which was the hardest of the three vessels, looks pristine. And now a follow-up question is that, is there any purpose? Is it an overkill to do IVUS of the circumflex?
No, that's overkill, because rewiring, okay, you have to go through that left main. We are up to the ostium, he's saying. Okay, once you think you're done, you should not go back with the guide, because every time you engage the guide and you're trying to do something, there's a risk of LSD now. Okay, since we are up to the stent is up to the ostium. So if you don't need it, you don't need it. It's not, so you have to go through the left main stent, the crushed, I don't know, though we have opened it very well, and then get into the circ to rewire and IVUS it. No.
I hope that is a convincing suggestion to the numerous people who asked this question simultaneously. And Dr. Kinney provided her rationale not to proceed there. And of course, the follow-up there was that, considering he's young, I think well mentioned, but I think taken care of. Anu, what else would you do for this young patient? How would you follow him through a CTA, stress thallium? What would we be doing? I see Dr. Sharma back in the room.
Yeah.
Maybe he could answer this question. Samin, how would you follow this patient? Thallium stress test or a CTA?
So very good point.
The current CTA, they have not reached, though they're saying there's a new generation coming up in the next couple of months where they can even see within the stent, ISR or no ISR. Otherwise, ideally, once upon a years ago, we used to routinely bring these patients back. But this guy, I think at one, he did have symptoms, so we know his symptoms will return. The other thing was, then you have to do a stress test at 1 year. At 1 year, if everything is okay, then you just follow them, because routine stress testing without symptoms is actually class 3 in guidelines right now. But all his numbers should be followed through. His LDL is 102. We'll make sure that
80 now, right?
91
80,
today.
90,
okay,
keep going
91.
down, yeah.
close to 50.
55,
55 for American guidelines, 45 for European guidelines. So
Go to
let's
the
make it
slides.
50.
Yeah.
And his hemoglobin A1C is 5.8, which means that he need to change his eating. Less carbs, more protein.
But it's still less than 6. Yeah. So just coming back to the point, definitely will not do the thallium test on this because it's negative now with this disease. So I would say now as Anu mentioned, the 1056, that photon CTA will be more accurate, or do the angiogram. So I would say that many of the complex cases, particularly when there is an option for surgery, such a young person, I would settle nothing less than doing another angiogram. I know we are away from doing the routine angiogram, but some cases we still do, and this will be the ideal case for repeat angiogram.
You did not see the final picture. They were concerned about
Samir,
here.
Yeah.
At 3 months or 6 months?
No, I would say 8 months, 6 to 8 months. Yeah. So it's okay. Why?
No, they were concerned about the little dissection we
circumflex.
discussed. Yeah, we discussed to leave it alone.
That's but now we can change what antiplatelet therapy?
No, Will decided he wants to give Efficient.
Efficient, beautiful. So this is the case, you need a stronger antiplatelet therapy and will be all right. And if you require, you can always give a 1 bolus of 2B3A, which is eptafebatide in this particular case. So coming back to the points here, recent key CAD and interventional publications, which is the BioAscend ISR trial, BioAdapter randomized clinical trial of 2-year results, then exact phase 3 angiogenic gene therapy trial. So angiogenic therapy coming back, and the woman's health study 30-year outcome. And then focus review of the month is colchicine and acute MI, early and long-term outcomes of colchicine after acute MI, PCI. Clear synergy OSIS 9 trial. So let's go to one by one. Quickly, BioAscend. Basically, as I mentioned, drug-coated balloon is going up. Our review article recently in JAMA Cardiology has attracted a lot of attention, and it's actually used this from 5% to 40% globally. Many places in Europe use 40% drug-coated balloons. So now there are a lot of comparison of the sirolimus versus paclitaxel. Now the same thing like A9, the DES, so biolimus coated versus paclitaxel coated. This is the BioAscend. In China, basically the concept is the same. The biolimus versus paclitaxel, around 140 cases, and overall no difference in individual data. MLD identical at follow-up. As you can see here, 1.9 and restenosis, and this is the frequency distribution curve. At late loss was 0.25 in the biolimus, and paclitaxel is 0.27. Identical with individual endpoints as you see here. TLF, cardiac death, MI, identical. TLR kind of little bit favored paclitaxel. 12.9 in biolimus versus 7.9, although it did not make a statistical significance. Okay, what happened to the slide now? So basically, it turns out to be the biolimus is as good as paclitaxel, which has been tried in a numerous thousands of patient trial, and so let's say good. And then, so this basically the second is BioAdapter randomized clinical trial. It's a 2-year outcome of the sirolimus eluting BioAdapter versus zetorolimus eluting drug, which is Onyx. And basically, this was a bioabsorbable polymer. As you can see, the sinusoids are covered with that, and this was the special dynamic X bioadapter. Basically, the whole idea is that after 6 months, when there is unlock and there is a polymer resorption of the stent, that how will it show? First data at 1 year data, which have been published already in Lancet, showed that you have a lower late loss, and more importantly, restored pulsatility and adaptive coronary flow volume with the bioadapter. So it was effective in a 1 year data with a lower plaque volume, and so many of them, even lipid containing lesion, it was a negative remodeling, which is good. So no plaque. So this is 1 year data. Now we have the 2-year follow-up of the same patients. Clearly, bioadapter continues to do quite well with the event rate of 2.3 versus 5.5. P-value just made it to 0.093, as you can see here. But individual endpoints are here. 5.5 TLF goes down to 1.9. P-value for superiority, and each individual endpoint of the cardiovascular death, MI and TLR, was not different, and they also took into the more complex lesion and LAD. The benefit was even more. In the complex lesion, as you see, in the small vessel, long vessels, 0 restenosis, TLF, and of course significantly 8.7 goes down to 1.9 in the LAD. So this basically is the bioadapter randomized clinical trial as a bioabsorbable polymer, totally different concept. We'll hear more about it. Then the data on basically the angiogenic gene therapy for refractory angina done in United States called EXACT trial. A small number of patients, 33 basically, and the patients got the gene. It's just a basically a dose finding and dose administration study with the exercise duration and change in exercise duration at 3 months, 6 months, 12 months, clearly showing that by doing the gene, you're able to improve the exercise tolerance, and ST segment depression occur at the later time period as we go along. And more important, the graphic extract, as you can see here, treadmill time, ischemia on PET scanning, angina frequency continues to better by using this gene. Now, this is a special VEGF, and this is first of its very kind given transepicardial injection, and this is a small study to look into this phase 1 and phase 2 with a 3 and 29 told 32 patients, but more need to come. This I think we're going to start now into the randomized fashion. So basically this gene XC001 administered via transepicardial delivery is safe and generally well tolerated. Exploratory improvements in total exercise duration, ischemic burden, and subjective measures support a biological effect sustained to 12 months, warranting further investigation. So plus point to the gene therapy. Then another study which I said CAD versus intervention. This is the women's health study, and they came up with a 30-year cardiovascular outcome. Remember, we know the known factors of the age, sex, family history, and all those. But what about giving? Of course, the original trial was the low dose aspirin and vitamin E for primary prevention in the healthy women. These were the age was 54.7, mean BMI 25.9, hypertension, smoker, diabetes shown there. And basically idea was the what is the predictive value of the 3 common factors, chemical markers, HSCRP, LDL-C, and LP(a) in various quintiles. And you can see here, individually quintile, all of them are associated with increasing event rate. As you can see here, the number of patients, more importantly, the HSCRP, LDL-C, and LP(a) all have an individual go to from Q1 to Q5, higher event rate, but if you combine all 3 of them, your predictive value even become more important. Whether 1 factor, 2 factor, or 3 factors, as you can see here, MACE, coronary heart disease events, stroke, everything correlate when you have all the 3 markers are there. So it was very simple way. The single combined measure of high sensitivity CRP, LDL cholesterol, and lipoprotein level among initially healthy US women was predictive of incident cardiovascular event during 30-year follow-up. These data support efforts to extend strategies for the primary prevention of atherosclerotic event beyond traditional 10-year estimates of risk. So clearly that whatever we do, but this gives you additional power or additional marker for the subsequent event. So next one is colchicine in acute MI. Colchicine actually has been in the news for last 4 or 5 years from various trials, and particularly has become now even class 2A with the European Society of Cardiology, our latest recommendation, although there is no clear recommendation from United States, but the even drug is available. They made a separate Lodo tablets, and this basically was early and long-term colchicine after acute MI, and basically showed earlier data of the Colcut, acute MI, Lodoco 2, all showed benefit of colchicine, lower event rate. And of course, you can see that only disadvantage was trend towards higher non-cardiac death and more infection and pneumonia. So that was shown so far in the trial. So this is the meta-analysis overall showing that inhibition of inflammation, potential mechanism of the neutrophil chemotaxis adhesion and activation, inhibition of the neutrophil platelet interaction, all led to lower MI, lower stroke rate, lower coronary revascularization, and no difference in cardiovascular death, slightly increase in the non-cardiovascular death and infection. That was we learned from the meta-analysis. Then they did a trial for neurologic event, convince and change chance 3, no difference. So basically, positive area now start becoming negative, and then to add to it, the region is Y. As you know, the colchicine basically work on the cytoskeleton, on the tubules and of the various inflammatory pathway, and cause the other chemical inhibitions also all lead to a decrease in inflammation and macrophage. So this is the clear synergy trial, which basically was 2 factorial design, colchicine versus spironolactone, colchicine 0.5 milligram daily, spironolactone 25 milligram daily. Patient with acute MI referred for PCI from 2018 to November 2022. See, this is a period of the COVID also, and all those patients received synergy. That's why the name is Clear Synergy OASIS 9 trial. And composite endpoint, individual points are here. The STEMI was in 95% of cases. Some of them were non-STEMI. Diabetes was in 18.7%. Medical therapy, as you can see, is shown ticagrelor and clopidogrel equally divided. So majority of them got the drug-eluting stent. Very few got angioplasty only. They didn't say who got the drug-coated balloon, but overall were comparison with half of them multivessel disease. As we knew that C-reactive protein decreases with colchicine, that was consistent in this. It started with C-reactive protein of 10.4 and it went down to 4.3 in the placebo group and 3 in the colchicine group. So significant reduction in inflammatory marker as measured by the CRP. Now, but what about the rest? Rest you can see given for 5 years. Or the drug was given at least for 3 years, but 5-year data, 8.3 versus 7.9, 5-year outcome of MI, stroke, new or worsening heart failure, and death from cardiovascular causes. Identical. Everybody was shocked. This was presented in the TCT, and then subsequently spironolactone study also showed no benefit, and individual endpoints are here, exactly identical in every aspect of your MACE. Primary and secondary outcomes. And then you also found that particularly the few good things I would say, the death from non-cardiovascular causes, which actually have been blamed on colchicine, this large study showed no difference. Rather, it was lower non-cardiac death. So that's a very interesting point. And of course, the pericarditis, we give colchicine for pericarditis, but there was slightly numerically higher pericarditis. But otherwise, no important endpoints of the primary and secondary prevention. Serious side effects were identical except more diarrhea in the colchicine group. And very interesting observation of the pre-specified subgroups. One thing they knew that if patient weight was more than 70 kilo, so they gave actually patients 70 kilo, we give once a day or twice a day. And you saw that once you gave twice a day, more than 70 kilo, in the middle had a lower event rate, 0.61 to 1. Odd ratio 0.78. So question is, we have been talking about once a day medicine. What about colchicine for atherosclerosis prevention? For this benefit, maybe should be twice a day rather than once a day, but that's a hypothetical we learned. So among patients who had MI, treatment with colchicine when started soon after MI and continued for median of 3 years did not reduce the incidence of composite primary outcome, death, recurrent MI, stroke or unplanned ischemic coronary revascularization. And they actually also started making, NEJM also started making the central illustration, as you can see here. Very interesting. I saw the first time from the NEJM also that they have the one-page central illustration, basically a lot of the pictorial pictures and so. So question is why it was negative. So I think one of them was that it was all patients got the stent. So what has shown that colchicine has a transendothelial migration of the leukocyte, impaired expression of the tissue plasminogen activator, and enhanced expression of plasminogen activator type 1 in endothelial cell, which impaired migration of endothelial. So once you do a DES and you give some medicine to decrease endothelialization, was really troublesome. And this actually has been shown that colchicine inhibit the vascular EGF and the vascular endothelial growth factor and endothelial proliferation. So therefore, some effect of colchicine if you start very early may be negative, and that may be one of the mechanisms why it was negative in this such a large trial. So just to sum it up, take home messages: Biolimus versus paclitaxel DCB, both were identical, no difference. Dynama X bioadapter versus Onyx DES in native CAD has a plus point because of the natural pulsatility. the angiogenic gene therapy for refractory angina, a good indication, and then measurement of the CRP, LDL, and LP laterally for cardiovascular event over and above the rest of the prediction model at 30 years is plus. So therefore, the large global randomized clinical trial of colchicine versus placebo early after STEMI failed to show any benefit in reduction of major event rate. Colchicine use significantly reduced CRP at 3 months with higher incidence of diarrhea and no difference in non-cardiac death, pneumonia, or serious infection. So key is inflammation. We know that now there are like 3 or 4 other trials of the inflammation, all have failed. So colchicine now gets into the same bucket. The anti-inflammatory for atherosclerosis, the way we use it may not be active, may not be working. So we still need to wait many other anti-inflammatory trials targeting specific receptor blockers which are coming. But overall, I would say, knowing what the inflammation field, besides just using the statin, that everything else has failed. This paradoxical observation compared to earlier positive data of colchicine has serious issues about its role in CAD. So we actually were not using much colchicine and CAD. Now, Anu, what about you? I can tell you we are using in stable, never using acute coronary syndrome, in refractory angina. My feeling was when this whole thing came up with the Lodoco 2, we started using and benefit was 10%. I stopped using it now. But yes, they made to the guideline because of the randomized trial as a 2A in the European, 2B in European society, but no guideline from the America. But now with this major trial, I would say it will become class 3. That no benefit, no harm, but no benefit. So let's come.
The question
There is
is,
harm, diarrhea.
Yeah.
would it have any role in those patients who are not going for PCI? You're not considering.
Yeah. So if we go back to our earlier trials, it may suggest some benefit because we have that earlier data, but I will still be very concerned about what we learned in this major trial. But you are right. So if you are just doing a medical management, in addition to giving, now is it because we got more stronger antiplatelet therapy in these patients? And so whatever the mechanism was, or the stent really the equalizer in these patients with a complex CAD is all need to be seen. But yes, the alone medical therapy management, the question is, are they going to do another trial using it in a stable CAD? That will be the big issue now. So anyway, let's come to the final 3 questions. Following statements are true regarding the BioAscend ISR trial comparing BCB versus PCB, except means what is wrong. Similar TVF, similar target vessel MI, higher TLR in paclitaxel group versus bioluminescence, similar death rates between 2 groups, similar late lumen loss. So clearly answer is C. The higher TLR in the PCB group, no. Second, following statement is false regarding the results of bioadapter randomized trial of Dynamax X stent versus Resolute Onyx. Better vascular percelity with Dynamax X, lower plaque progression in Dynamax X, lower TLF in Dynamax X, numerically lower TLR in Dynamax X, and lower TLF benefit in LAD with Dynamax X. And answer is E. The false is because there is more benefit in the LAD and complex cases using the Dynamax X. The lastly, following statement is true regarding the results of the colchicine versus placebo trial after AMI PCI in the clear synergy trial. Lower MACE rates with colchicine versus placebo, lower revascularization with colchicine versus placebo, lower MI with colchicine versus placebo, lower CRP with colchicine versus placebo, lower diarrhea with colchicine versus placebo. Clearly answer is D. There was a lower CRP with the colchicine versus placebo, and everything was identical. With that note, I complete my presentation.
Samin, outstanding review. Anu, final summary teaching tips. What should be the takeaway message from the technical point of view? One of the things I can tell you straight away was your insistence that you're going to focus on two vessels at the moment and stay away from putting three guide wires. But overall, your views.
No, I think we showed the steps of mini crush. Again, we keep insisting on the technique, learn one technique and keep doing the same technique, get better at it. Somehow we cannot change the world to go away from DK crush. So there's no comparison between DK crush and mini crush. I think we've shown the same steps how to do it faster and in a slick way. More reason is the more wires, more devices, the longer you take, then you have issues. So our total time was just 24 minutes, just the procedure fluoro time, and air karma was 1.7 with a contrast of 160.
Superb skill, excellent teaching points. I want to thank our viewers. Be sure whether you watch this case, you want to answer the questions now, or the archive cases, do claim your CME. We'll see you during the next transmission on March the 18th.